a very, very, very large entry point. And then we're going to begin to link the integration strategies to quality incentive metrics. So a lot to cover. I got 30 minutes. We'll see how it goes. So I'm going to talk a little bit about the toolkit. I want you to pay attention to what I have underlined here. So this is what is in the toolkit for what we need to focus on for bidirectional integration. The thing that I think people miss is that we need to address behavioral health needs in one system through an integrated network. Now, this isn't a financial network. I think part of it's financial, and with the everything coming together in terms of the MCOs and the BHOs and all that. I think the thing that people miss in this and aren't quite grasping, and I'm telling you, I'm bringing you experience from Greater Columbia ACH, is the clinical aspects in which we integrate the system. There's a lot of work that needs to be done to marry these things in a meaningful way so that we can move forward. So that's really important, and it's got to support the Healthier Washington movement. So I know this is a super busy slide because it's a super busy toolkit. And what I want to focus on here is these metrics. And I don't know how many people have really kind of researched and kind of gotten into the nitty-gritty about the metrics, but there's really what you need to know is there's two levels of metrics, okay? There are overarching metrics that are at the statewide the statewide metrics that all the ACHs are going to be responsible for. And those are outlined in red here. So basically, how we do as an ACH depends on how well we do. This is the measuring stick on these specific metrics, okay? Now, these are metrics that are across all ACHs. These are metrics that we don't necessarily get to choose. They're chosen for us, and we need to keep our eye on the ball with those. Then there's project level metrics. Now these project level metrics, and these are more specifically related to behavioral health, are metrics that we get to kind of pick and choose. This is more of a menu set, right? These project level metrics are things that we need to keep our eye on and choose our metrics and align these metrics with what we're doing from an integration standpoint. Now, to my knowledge, and I think this is correct, you guys haven't chosen these metrics yet. Am I correct, or haven't really?
That is correct.
That is correct. Okay. So we're going to want to talk about that because this is going to be really important. We need to start with the end in mind. We need to think about these metrics. We need to think about these project metrics and these statewide metrics as we build the system. There has to be alignment with how we're building the system and to how we're measuring how the system functions, which is according to these metrics. So that's kind of the overarching discussion I want to have today is how do we do that? How do we do that in a meaningful way where this isn't about metrics? It is about metrics, but it isn't just about metrics. It's about people. And it's about doing a good job of meeting the needs of people out here in Eastern Washington. So what I want to talk about here is there's really 4 choices, per se, around integration, okay? And this is what the HCA has outlined for us in terms of what integration looks like, what we can kind of pick from so we can fund integration. Now, 2 of these choices are primary care based, 2 of these choices are more community mental health based, all right? And so it doesn't mean that there can't be other community resources. I hear a lot of people here from community level resources. All of you are important, and I'll show you what this all looks like. But kind of the epicenter of these choices has to be linked to one of these models, okay? And what I'm going to argue is that it needs to be linked to all of these models in a meaningful way, all right? So I'm just going to kind of briefly outline. I'm going to skip the BRIE Collaborative. So I was on the BRIE Collaborative, and I'm going to talk a little bit about the BRIE Collaborative. The BRIE Collaborative was a stakeholder group that convened in 2016 to bring people together to come up with clinical metrics and clinical guidelines around how we actually do integration, not just financially, but clinically. And I'm going to talk about BRIE a little bit later because I think BRIE does a good job of synergizing the BREE concepts, really do a good job of synergizing specifically what we're looking at for primary care integration. Collaborative care. How many people have heard of collaborative care? Exactly. I thought everybody, right? A lot of people, because this is Washington, the home of collaborative care, right? So collaborative care model is a very good model in what it does, but it's not the panacea of behavioral health integration. Neither are any of these. But one thing that I've seen in this state particularly is that a lot of times there's basically this idea that if we're integrating in primary care, if we're not doing collaborative care, like there's something wrong, which isn't the case, and I'm going to talk a little bit about it. Collaborative care is extremely important, but it isn't going to serve everybody that needs to be served. In that sense, too, we need collaborative care and the concepts it brings to measure what we're doing well. So I'm going to talk a little bit more about that. But collaborative care, for those of you that are unfamiliar, basically focuses on the concept that we're going to, in primary care, do a good job of tracking people that come in, specifically around disease state, usually depression. They come into the clinic, they screen for depression, we put them in a registry, we do some care management, care coordination, and if they're not improving, we link them up with psychiatry. And we continue to follow them until they improve. That is collaborative care in a nutshell. And at the same time, the care coordinator helps to link among resources in the community and primary care, and that's really, in essence, collaborative care. The thing about collaborative care, and we're going to talk about this, is collaborative care can, if you're very much intensely coordinating care and managing the population intensely, it's really hard to manage a very, very large subset of the population doing that, okay? Especially to match the needs of the services that are out there. So we'll talk about the value of collaborative care and how it becomes optimized in the context of other models. The other thing I want to talk a little bit about is the integration in behavioral health settings. So really there's two options here. One option is you do community mental health and you do a really good job of coordinating with a physical health entity. Okay, so like primary care, and you begin to develop some shared communication. You can have separate care plans in the off-site enhanced coordination model, where you just communicate about those and pay attention to physical health. In the co-located enhanced coordination, it's actually what we call kind of a behavioral health home. How many people have heard of behavioral health home term? The behavioral health home is basically this on-site enhanced collaboration where you put a physical health provider, like a medical doctor, PA, nurse practitioner, in a behavioral health setting, and you go to the behavioral health setting and meet the physical health needs of those folks that are engaged in the behavioral health setting. It's very important, very, very important, because a lot of those people who have serious mental illness are at great risk for health complications, early death, those kinds of things. So that's very important. But also, again, that's not it. If we just do that, we're going to miss a large subset of the population. So again, it's starting to think about how do these things fit together. So I want to talk a little bit about, and I just want to call out kind of where I'm at. I don't know exactly what I've gone through some of your project submissions, not very much in depth, because I wanted to kind of just talk a little bit more conceptually today. But from what we saw in Greater Columbia initially when we were starting was that there was a lot of project submissions that kind of hovered around these four models, right? They kind of pretty much expanded one of these models, or they took these specialty resources in the community, right? And they connected one of these models with a specialty resource. And I think that is good. But I think if our projects only focus on that, we're going to still miss the ball here. And when I say miss the ball, I say I want you to think back to the early slides I had about the quality incentive metrics. So, care coordinating these models with community resources, peer services, I think the thing I want to say is these are all good things. The thing that we need to do is we need to figure out how to take these models and put them more like this. We need to be able to take the models that are out there and put them more in an inner working way, and that be the hub of where behavioral health integration starts. So if we're going to start integrated care, we need to think about this as being the vortex of where we need to start, and these models working well together, and then looking more at coordinating that with all these other resources. And I'm going to show you kind of what I'm thinking and how that looks like, and the ACH kind of being a part of that. So this is, I know this is a busy slide, but I think that what I want to have people understand is that in order to think about behavioral health integration in a meaningful way, we need to think about an integrated system that is set up with the no wrong door approach, where we, realistically match our level of intervention with the level of treatment needed by patients. Okay, so if you look all the way over here, you've got primary care all the way down to inpatient treatment and everything in between, and some community partners and peer resources that are kind of span that continuum. I think the point is here that these entities all have to work together so that we can adequately parse out the resources to meet the various interventional needs of our population. Now, in a perfect world, the low-end people would end up in primary care, and all of the higher-end folks would end up over here. It doesn't happen like that. Why? Because there's this thing called patient motivation, and these are people. So it doesn't always end up like that. This is a conceptual drawing around where we need to think about the level of complexity and level of intervention, but I can say that this isn't what is. This is a conceptual idea of how we need to think about the continuum of behavioral health care and matching the needs and level of intervention. And I think what you begin to see is that the population is largest here and becomes smaller as you get further down the continuum, right? Because the inpatient treatment, folks, is a lot smaller than what you would see in primary care, right? So, and then community partners kind of make sense. So this is in essence what we want to strive for, and be able to take those four models and concepts. Now, collaborative care is kind of on its own there, and I'm going to talk about how Bree kind of combines these two in a second. And again, these are the off-site, on-site coordination. But what I'm trying to get you to see is that when you think about it like this, these are actually systems that interface in a meaningful way. Now, there's going to be coordination from off-site into primary care, there's going to be specialty care, and there's going to be referrals and care coordination and community partners in that process. But what we need to think about is if we haven't put these models together in a way where they're sharing care across the ACH, then they're just going to be a bunch of projects. And we can't do that. We can't do that because we're not going to be able to meet the metrics. And we're also not going to be able to provide really outstanding holistic care to the community, which is more important. So I'm going to focus today on primary care, and I want you to know that because I'm focusing on primary care doesn't mean that I don't think the other parts are important. I want to reiterate that. It doesn't mean that I don't think the other parts are important, because they absolutely are. And in fact, primary care can't operate effectively without assistance from other folks in the community across the continuum of care. So I want to talk about the conceptual idea of why primary care is so important and why we need to be vigilant about paying attention to doing a really good job of integrating behavioral health and primary care. Again, not the panacea, but a really important concept to understand as we begin to look forward into behavioral health integration. So let's just take some general statistics. If you think about 11% of primary care patients with depression and 19% of anxiety, which is what the research shows, okay? Just think about that for a second. And you think about a PCP's panel, okay? Let's do the math here. Average primary care provider panel is around 2,300. That's what we see. That's what a lot of the research out there shows. So an average primary care practice tends to be roughly 3 docs, 3 providers. So an average practice is around 6,900. So I kind of went in the middle here saying 15% needed behavioral health service. Not 11, not 19, I kind of went in the middle. So for each practice, for each average practice, that's 759 people. How many practices do you think we have in the ACH? A lot, right? I don't need to get in and break that down, but a lot. Thousands and thousands and thousands of people needing care. And they're interfacing right here in primary care. Now, I want you to think about this conceptually. Let's say we had thousands and thousands and thousands and thousands of diabetics, okay? Which we have thousands, but not thousands and thousands, right? And let's say, you know, guys, you've got diabetes, you need to go see an endocrinologist. We just didn't treat it well in primary care. We needed to send everybody out in the community to go see an endocrinologist. What would happen? We'd have not enough endocrinologists. We'd have an uproar. We'd have people who are tired of waiting to get in. We would have people who are frustrated because they're not getting care. We'd have people become unengaged in the process. We'd have people drop off and fall through the cracks. What does this sound like? It sounds like our current mental health system, right? It's a reality. And we need to think about that. We need to think about how we actually position ourselves in medical care and position ourselves in behavioral health care in the same way. So, right, this is my whole endocrinologist thing, right? So at the old days, you know, old RSN days, we just refer them out. The problem is not everybody has mental health benefits. Some people have physical health benefits, but they don't have mental health benefits, or they don't understand their mental health benefits. Huge one here, stigma. So imagine that diabetes was the worst thing to have and you didn't want to talk about it, okay? It'd be challenging. Then you have the mental health process and wait time, the intakes, getting in. People want care people want help when they go to seek care. They don't want to wait 3 weeks or 4 weeks. Now, I'm not blaming the community mental health centers for that. The problem is we haven't designed a system to support the community mental health centers to be more efficient in what they do, because we need them. Just like we need endocrinologists for diabetics that need a higher level of care. We need specialty mental health care for patients in primary care that need a higher level of care. So, but we have to set them up for success. And the way we do that is we design a primary care behavioral health system, okay? Primary care behavioral health system is one in which the mental health system is designed like primary care. It's brief, it's episodic, it sees a large subset of people, it gives people help when they seek it, and that becomes a huge part of what we need to do. And where do we need to put it? Well, we need to put it in primary care, because that's where people show up. That's where people are already. We don't have to go find these people. They're already there. They show up every day. And those things that we talked about mental health benefits. Well, the good news is we've got some movement in the legislative process. I was involved in Senate Bill 5779, which basically is a short-term type of fee-for-service arrangement where there's going to be a matrix and there's going to be something coming out. I don't know if any of you have gotten emails already from the Healthcare Authority, but they've designed a matrix that mandates them to pay for integrated behavioral health care in any setting by any licensed provider and using any code that's applicable to the license. That was a huge, huge, huge win. And that passed about a month and a half ago. What that does is it allows us to build the infrastructure in primary care without losing money. Because nobody wants to build a service that they can't sustain, or at least that they have to lose money at for, to get it started. Okay? So look up Senate Bill 5779 if you're not familiar with it. It's really important. Basically what it is it's a Band-Aid until we get to fully integrated care in 2020. It basically helps us start to build the infrastructure without losing money until we get to a value-based payment. So, oh, by the way, when we build that infrastructure, we need to make sure it aligns with the value-based payment, because that's eventually how we're going to be paid, right? So stigma, again, we talked about stigma. We need to be able to have primary care with a focus on same-day visits. We need to be able to accommodate people the same day they come in and get service. It's just as simple. It's non-simple as that, right? But it's extremely important because people are motivated, they're there, and they want care. So we have to make sure. We almost have to imagine it like we're taking our own children to the doctor. And we're going to see the pediatrician, but the pediatrician may not have the answer, but you need a little bit more intervention. But imagine how hard it's going to be to try to get your child in care and get them off school and do all that, right? You have to think about it like that. We need to do this because it's the right thing to do, okay? So, same-day intervention, short episodic care. Short episodic care means I come in, I get a couple visits. If I'm feeling better, I don't need to come back. Maybe I just need 1 or 2 visits. Remember, this is how primary care operates. You're sick, you go into the doctor, you get some care, a prescription, you don't need to come back, you don't come back. If you need to come back in 6 weeks, you come back in 6 weeks. If you need to come back 3 or 4 times, you come back 3 or 4 times. We need to design a behavioral health system like that. And we're actually doing this at Unified Community Health in our clinics and across the Yakima Valley Farm Workers Clinic. And that has become kind of the hub of where our behavioral health program is really focused. So, and then, in primary care, there's, we're going to talk about this, but there's a subset of people that come every week or every 2 weeks. And we need to be able to treat them as well. And we need to be able to provide coordinated treatment with the primary care provider. And even though we might want those people to go to specialty health, mental health, because they need it, they may not be ready. So we need to work on engagement. So what does the primary care behavioral health workflow look like? Well, the primary care provider and the behavioral health consultant work side by side. Whenever an issue is identified, you go in the exam room, and you go in as a normal part of care. You're just a normal part of the healthcare team, okay? What I'm noticing in the state of Washington is, unlike other states, this is not as prevalent as it is in other states. And this is really kind of that Jenga piece. Again, if we're not offering the behavioral health at the point of care, then we're going to be missing a lot of people. And the primary care providers, at the same time, don't necessarily have tabs on where to send people, or they don't really have the time to diagnose or dive into the mental health problems. So what happens? These people keep cycling through primary care. They end up in the ED. They end up on the street. They end up using. We have to be able to provide service when people come in because they're ready today. So this is a great start to build an infrastructure. We need to make sure this is in place. But again, this is not the panacea. This is not the panacea. Because when you're doing all this work, guess what's really hard to do? It's really hard to measure and keep a registry and track outcomes and care coordinate, and it's really hard. Imagine a primary care provider if they had to see all their patients every day and do all the care management for their patients and run the registries and do all that. Some primary care providers are doing that and not well, but a lot of practices have moved in the context of patient-centered medical home where they have other people doing that work so they can be better primary care providers. So again, this is not the panacea, but this is an important piece of integration that we need to keep our eye on. So, how do we optimize this? Well, we need to think about some of the aspects of collaborative care. Because collaborative care, what do they do? What does that model do well? Well, collaborative care does a great job of tracking care coordination, linkage with psychiatry, instruments, population management. So there's a lot of really good things that collaborative care does. And if we can work on finding the synergy among collaborative care with this other kind of warm handoff, fully integrated primary care model, now we're onto something. Because if we do a really good job of providing access to care, and we do a really good job of tracking it, and we do a really good job of engaging people and understanding diagnostically where they're at, their level of motivation, then we can help the right people the people who are motivated and qualified and want to go to specialty mental health, we can help them get there, rather than sending people into the abyss, because that happens a lot. And I hear it, all the time, that I sent them there and they didn't show up in their back, or they didn't have capacity, or the patient just didn't want to go. So we have to think about how these models come together, specifically these primary care models, because the rest of the system depends on them coming together. The rest of the system depends on primary care integration, because otherwise the rest of the system's overwhelmed, or the rest of the system isn't getting the population that needs the help, because either A, they're on the streets because they came into primary care, didn't get the help they needed, didn't come back, or they just keep cycling through primary care and the primary care providers don't have enough time and resources to manage their needs. So primary care becomes a haven for engagement and brief intervention, and a pivot point, an access point to help the rest of the behavioral health system function more effectively. Okay? So, here's the models, and how long do I have, by the way? 10 minutes, okay. I'll try to make sure I get through. I know there's a lot of content. So, primary care behavioral health model, treat all comers, high volume, brief episodic care, same day access, health behavior change. So the other thing the primary care behavioral health model does, works on health behavior change, smoking cessation, weight loss, other things that are in those metrics. That fully integrated primary care behavioral health model works on that. However, collaborative care does a really good job with registries, tracking, follow-up, condition-focused outcomes. And then what we need is that synergy around screening and tracking, collaboration, risk stratification. If we bring these models together in a meaningful way, and I think I just want to be transparent. I don't have the answer, and there's not one way to bring these together. There's a lot of ways to bring these together, and part of it is understanding your resources and starting to think about creating this kind of synergy in primary care, because it is important if you're working in primary care. And if you're a partner out in the community, it's starting to talk about what are you doing in primary care so that you can identify and treat needs, so that you're not sending everybody to us, or you're sending the right people to us, or that they qualify for us. So you want to kind of encourage this so that the people that actually need help and are motivated are showing up in those community partner agencies. Okay. I'm going to talk a little bit about the BREE Collaborative. So I was part of the BREE Collaborative. I was part of the work group that helped develop these guidelines. BREE Collaborative is kind of one of those things that showed up on the toolkit that everybody's like, yeah, BREE Collaborative, yeah. Okay, let's see what's next. Not a lot of people really, I think the more I'm kind of hearing about it, there's not a lot of people that really understand what is the BREE Collaborative. Here's what it is, all right? There's a group of stakeholders that came together that said we need to come up with some clinical recommendations that make sense. We need to find a way to synergize what's going on out there. And the BREE Collaborative it really focuses, it's a stakeholder group that came together. And we came up with a report, all right? These were people that were doing collaborative care, people that were doing primary care behavioral health, people that were doing outpatient work, people that were community partners. A whole bunch of people from various aspects of care came together to come up with these guidelines, okay? And the report's down here. And I'm happy to share these slides afterwards if anybody wants them, by the way. So I want to march through these pretty quickly, because what the BREE Collaborative was intending to do was to synergize what I was basically talking about, was trying to create this synergy among providing good access and good care coordination, good tracking in primary care. BREE Collaborative was focused on primary care, and that's a shortcoming. And why? Because that's a large chunk of work to bite off. And so I expect there's going to be another BREE Collaborative document that focuses more on specialty care, and then a relationship between those documents eventually. I see that coming, but primary care was a big piece of work that Healthcare Authority wanted us to dive into, so we focused on primary care to start out with. So one of the things that's really important I want to point out is the routine access piece. The BRIE Collaborative, we all came together and said, look, if we're not providing same-day access or close to same-day access, we're not doing a good job in primary care. Because you can call up your primary care provider and get same-day access or pretty close to same-day access. We need to do the same thing for behavioral health care, okay? So these are the elements that we came up with. There has to be a care team, there has to be routine access. When you say integrated, integrated translates to routine. If it's not routine, it's not integrated. Accessibility and sharing of information. If you're going to have integrated routine care, guess what? All the information has to live in the same place, right? I can't be guessing where the information is and what medications are on. That's not integrated care. There has to be access to psychiatry service. We actually have to have, like medical care, access to psychiatry for people who need to step up in care, right? Because medical specialties have access to other specialties. So the same thing has to happen on the mental health side. There needs to be workflows to support population care. And this is consistent with patient-centered medical home. We need to have workflows to identify and screen people and understand what's going on and treat them accordingly, like we do in the health settings. The treatments need to be evidence-based. Patients need to be involved in the care. These are the guidelines. There's a lot more text in the actual BRIE report. So I'll pass these slides along, but it's helpful to understand that this was an attempt to synergize the primary care models. Because aspects of collaborative care, right, tracking, proactive identification, registries, this is really the summary of what BRIE Collaborative worked on. Routine same-day access, shared care plan, access to psychiatry, screening, identification, stratification, and systematic tracking. That sounds a lot like primary care behavioral health model and collaborative care model kind of together, okay? So, all right, so this is kind of the drum roll where we're kind of waiting for. So what do we do about it, all right? So I kind of put it together. We need to again think about systems, behavioral system and the medical system. And in primary care, we need to have the overarching primary care behavioral health system, the primary care behavioral health model. We need to have some form of mental health integration project, collaborative care tracking piece. They don't necessarily, again, have to be those models. We're actually trying to combine collaborative care and primary care behavioral health in one of our clinics. And I'm not going to lie, it's kind of clunky. And we need to work on that. So that the concepts need to stay the same. The models don't necessarily have to be cut dry. So I can talk a little bit about that afterwards. But so we need to find a way to connect the behavioral health home. So the patients come through primary care. A lot of them come through primary care, get to the behavioral health home. And this is the other way around. When people their mental health needs get better, maybe they go back to primary care. The idea here is to create a system, okay? And connect the system with community resources, all right? Connect the medical and behavioral system. And again, these pyramids, again, there's more patients in the bigger part of the pyramid, right? And so ultimately, this is kind of what we should work towards for our system of care, okay? And again, we talked about it. That system needs to be built with these in mind. These things are important, and we need to think about choosing how we want to measure success. And I would say some of these are more hard metrics. Some of them are more process metrics. And I think that there's even more process metrics that need to go along with this to make sure that we're right on the roadmap. But the idea is we need to think about that system so that it looks something like this, okay? So we have system level metrics, we have project level metrics that ultimately should feed into this system and ultimately feed into the training tools and technology. And this is the challenge that we're faced with. This is what we want it to look like. If it doesn't interface together like this, then we're gonna miss the boat and it's just gonna be a bunch of projects. And that's really not gonna help us. So the question is, what's next? And to be honest, I think that that's up in the air. I think that there's a couple things I could think about. One, we need to do, and maybe this has already happened, we're doing this in Greater Columbia, we need to assess the behavioral health system as it is, current state. There's some instruments out there. Qualis is helping with the PCMHA, which focuses more on primary care. There's a specialty version of that. There's a tool called the MEHAF, which is specifically around behavioral health integration, and it actually aligns really well with the BREE collaborative elements. There's a crosswalk for that. What we're doing in Greater Columbia, which is kind of interesting, we're having community-based meetings with Qualis. We're going out, there's 9 counties. Greater Columbia is a gargantuan region. There's 9 counties, and we're going out to all these counties, and some of them we might be combining, and we're sitting down and saying, what's the current state of events here? What's going on in this county? We really want to know. We're getting people from the community. We're even getting people around the table. We anticipate fire, police, everybody around the table saying, where are the gaps in care? And a lot of what we're assuming is that some of that's going to be primary care too. Some of that's going to be community-based care. But so we're going to have some qualitative community-based meetings to really have discussions at the community level and county level, because each needs, especially rural versus urban communities, are very, very, very different. We're going to combine those in Greater Columbia, and that's going to help us come up with a roadmap. And then from the roadmap, we're looking at, we already have an established work group at Greater Columbia. So I think the question here is, do we start to pull people together? Do we start to have assessments? Do we start thinking more about how and there are existing projects out there. How do we connect those projects to other projects? And how do we connect bidirectional integration to opioid use and chronic disease management and all of that? Part of that still remains to be seen. And I think that this discussion was really hoped to foster some ideas around how that might happen. So, questions? Yes?
So, is there an assumption that the resource capacity exists and that the real challenge is creating that integrated network? Or is it a resource capacity gap, if you will? And the reason I ask that question is because in the urban area between the city and the valley, about 6 people a day are encountered by the EMS system. Mm-hmm. And every one of those people end up in an ambulance going to a hospital ED. Mm-hmm. About 60% of those people do not manifest as an acute behavioral issue.
Okay.
They're low acuity, and yet the only place we have to take them is the emergency department. Yep. In an ambulance. So either we are woefully ignorant of the resources that exist in the community, or we need to build capacity.
So we need to build the capacity. And I think the other piece that we need to think about is, I get this all the time, that, well, there's not enough mental health people. Well, there never will be exactly enough mental health people, but at the same time, we have to change the way the mental health system is actually being provided. And part of it is building the capacity in primary care so that you can interface with primary care. Most of these people that are getting picked up somewhere along the way have touched primary care. Most people that complete suicide, and there's some research around this, suicide completers have had a primary care visit within the last month before they complete suicide, right? Most of them. Most people touch primary care. So we have to be able to build the system and infrastructure like you're saying. And we also need to think about the conceptual model in which we're training people to operate to match that context. That's what we're not doing well. Yeah.
My name's Terry, and I'm the president of NAMI Spokane here in town, the National Alliance on Mental Illness. And I was looking at it, of course, very much from a mental health perspective as we're going through and explaining this. And I was wondering about the possibility of involving community groups such as NAMI that are not necessarily full-blown provider agencies, but they do aim at low-level and almost preventative care for mental illness. And if the system is looked at getting those involved to take some of the strain off of the system that, as we've just discussed, does not have enough providers there to meet the need.
So I'm trying to go back to this slide. This is where I see NAMI being a part of that. So where I see NAMI happening, and what I would love is more interface with NAMI and primary care, coming into primary care, doing groups, helping transition among this continuum of care, helping provide additional resource. So I see NAMI right here. I see NAMI going all across this, but particularly on this side of things. So absolutely, I think that if people are getting better here, we need peer support here. And we need peer support to help people move and navigate this better, right? So that's where I see NAMI.
All right, in order to keep us on track, I'm going to have to close questions, but Brian doesn't know this, but I'm going to volunteer him during the breakout sessions that we're going to have on the end for activities. If you all have more questions that you'd like to ask him, feel free to use that time. So we'll have about a half an hour at the end to continue. Everybody, a round of applause for Brian. Thank you. All right, now we're moving on to the section where we get to do all the fun ACH updates about the planning and project work we are doing. Last month, we did not have a Leadership Council meeting because we had our community project showcase where we heard from a number of you on your project ideas and how you'd like to sort of play with the toolkit and all Medicaid transformation. Today, we are going to, today we're going to be going over the scorecards that you all filled out during that event and some of the comments we heard back. I just want to do a quick reminder that I think that when we started doing the showcase project, we sort of had a different vision in mind about how we were going to be working through the project selection process. You often hear us say we're building the plane while we're flying it. So we have had some change thinking about sort of how we're doing this planning throughout until November when our projects are due. At this point, the feedback that we got from the scorecards is really going to be helpful to us as an accountability measure where we can start to see, okay, so is there still confusion from our community about partners? What's sounding really, really good? What issues are sounding really strong in this community? And also, as far as the criteria goes, where do we need to be worried? Where do we need to be sort of building up our capacity? What's really important to the feeling of our Leadership Council? So I'm going to ask Pam really quickly just to give a quick recap on how that showcase went while we get our technology switched over. And then Torney's going to present on the outcomes of that survey that you all took during the event.
Thank you. So first I will say the number of people that attended the showcase was amazing. It was standing room only. It was, I think, 3 hours that were allotted, and I don't know about everybody else, but I was thinking 3 hours, it's going to crawl. It did not crawl. It was done like that. It just went by so quickly. The breadth of the projects that were presented was amazing. So much connectivity and partnerships. Some of the projects were similar, but in different areas. And I also think that it's important to note that we got proposals from all areas of the ACH, which is amazing. I think, at least I'll speak for myself, thought maybe we'd be a little Spokane heavy. It really didn't turn out that way. There were projects throughout the ACH region, which was amazing. And some of the projects were creative, I think is the word I would use, but I was also really impressed with the people who went together and were willing to partner on things. And it'll be really interesting to see how we can take some of those and scale them up throughout the region. So I think at this point I'm going to turn it over to Torney and Devin to talk about the scoring.
Thanks, Hadley. What we did is we took the scorecards from each individual that went through the scoring, and we looked at each individual question, did an average of the outcome for that given question. So the little boxes highlighted there for the first presentation for the CHAZ project, for item number 1, the average that everybody gave that was a 2.93. So if you look at all of these boxes, that's what that represents. Then this software that we have allows us to go in there and create an outcome for each one of those measures. So if you look at all of the projects for the very first question, here's how they rank. And I can tell you what everybody in the room will do. You will look for your own organization to see where you fall. What's important for you to notice is that your relative position will change in each one of these measures. So in some places, the group thought you were really strong, but not quite as strong as someone else. And as you look down through this, there's a measure called a utility, and that is the combined value that gets assigned by this logical decisions for Windows program. What I will do here quickly is take you through each one of the measures. So notice where you are now in measure 1 for the first question. Here's where you went for the second one. And for the third. And the fourth. The fifth. The sixth. And the seventh. So what you perhaps notice throughout all of these is there's not dramatic differences. But when you recognize that in some of these scales you rank high, in some others you're in the middle or lower, what happens when you put it all together? And this is really the value of utilizing the software. What happens when we look at all of these indicators together is that you get this. Each color that is represented here is identified by one of the measures, and I apologize that it doesn't all show up on the screen because I have to scroll over here to get 5 and 6. But this is how they rank when you combine all 7 questions. Now, a challenge that we have at this point in time is that when we talk about what are those 7 questions, and you look at them in what is called a hierarchy, these were the questions that we were scoring for each individual project. This software will allow us to do a lot more than what we have demonstrated here today. And this will be something that Allison and her team needs to determine to what degree they want to pursue. First question is, for each response, there were 3 options, 1, 2, or 3. For each response within any given question, are each of those responses equal in value? Or is a 2 or a 3 more than the value that a 1 is? That is not something we determine. Right now, you're seeing it just as raw, plain value. So it is possible to have that make a difference in how much each one of these individual questions measures in terms of the score that you were given. An example from public health is that for us, primary care or primary prevention is considered to be much more important than secondary prevention or tertiary prevention. So when we use this internally in our agency, the primary prevention may get 60% of the score, where secondary gets 30 and 10% to tertiary. We could do that with each of these, but it takes sort of a process to say what is more important or not. If you leave the scores the same in terms of the proportionality for each one of the measures, the second challenge is weighting. Of these 7 questions, is any of them more important than the others? And if so, how much more important? And you can then adjust the weighting. What will happen with both of those processes is that you will start to see shifting in where you were, because as a community we say, yeah, this is most important, and we're going to give it a little more value or a little more weight, and it will change those outcomes. So that is work that can be done. If not, where we end up is what I showed you in the culmination prior, which is this one. Question? Yes?
Hi, it's Heidi from Meals on Wheels. What is going to be done with these scores? Like, what's the ultimate outcome of the scores are?
Allow me to turn the microphone over to
Before
Allison.
we answer that, I just want to make sure there aren't any more sort of technical questions.
So this is Julie. It's not a technical question. It's just weren't there 80 applications and we're only seeing, okay.
What you're seeing is the average per
Of 19 of the 80.
Just
of
the ones who
what-
presented.
of those that presented to us, because that's what we scored.
Okay, other questions for Torney? Otherwise, I'll get to the, what does this really mean? No? Okay, so the way we were thinking about this was really to try and inventory out where there was community interest across all of the optional project areas, with the idea that if it turned out nobody had any interest in, I won't say oral health today, but maternal and child health. We'll pick on the moms and kids today instead of our teeth. That would help inform our governing decisions around what the Healthcare Authority refers to as project selection, but our portfolio of projects. So one thing we wanted to see was there interest across all 8 or all 6 optional areas? And then secondly, was there interest across those areas across the entire region? So did we find, yes, there was full interest of everything, but it was only in Spokane County because Lincoln County's got it all figured out and they don't have any improvements to make. So that was probably our #1 goal because of both the strategy of how you earn the incentive payments in the waiver and the breadth of metrics that we're trying to move. And a lot of us like to be high achievers. So this idea, focus and really nail it, was super important until you started thinking about, we're going to just not do any maternal and child health, or we're not going to do oral health. It didn't quite sit with us. So we wanted to sort of test that set of assumptions. So getting 80 submissions was super, super interesting, helpful, showed we had great geographic diversity as well as project diversity. We did not expect 80. We expected 40, and we expected you could run through that in a showcase model using this piece. And it did go, as Pam said, it did go very fast. And I'm pretty sure if I kept you there till 11 o'clock with no wine, it would not have been nearly as much fun. So we also didn't want to put undue pressure on our partners who weren't in Spokane to, if you aren't there, you sort of lose out. And oh, by the way, if you're coming from Republic, that's a 2.5-hour drive and we're doing this after work. That's a lot different than asking Nadine to shoot on over from Catholic Charities. So we didn't want this to be if you don't present, you're sort of out. So we're really using this tool as, okay, we've got some set of criteria now. We have had an ability to, I would say, sort of have some interesting information about this. The people scoring, while many of you were in the room, board members, community members, had not read the full applications, and so forth. So there's a lot of sort of just flaw in that, which leads me to say, don't freak out if you were not #1, and it feels really, I gotta just say, sort of awkward that BHG scored well and that public health was #2, who was helping to run the evaluation piece. So because we all trust Torney so much, we know that no way would he ever be unethical or inappropriate. But I think use this as a point of reference, recognizing the limitations there. What will be helpful is the next part, which is the rest of our planning and where we're headed and how we see the matchmaking, partnership building as we move into the actual project portfolio development, and an evolving learning we're having around how important moving to value-based payment contracting is, who's going to hold the risk, and therefore the role they will play in their own partnership development. And that I think we should just move to my next slide, because I think this will make more sense as we talk about the planning process. And then I'm happy to go back to the showcase versus this. I I feel like I want to see and maybe even the next slide. Yeah, this is the slide that I want. So when we first were looking at the toolkit, we really envisioned there are 8 project initiative areas. And we all just started talking about these 8 projects we might do. And I appreciated Brian's comments so strongly as they relate to behavioral and physical health integration that you can't really think about these as individual projects, which very quickly moves you to, you can't actually decide not to do any of these if you're going to transform your health system. And so as we've thought about that, we needed to get a sense now of the inventory that is happening around our health system. So a couple of weeks ago, losing track of time here, we launched our health systems inventory. And this is a big lift, and we are grateful for all of our health systems who are actively participating in this. It's about a 12-page inventory that looks at all of the clinical models in the toolkit and asks them to tell us, what do you currently do? Because we know there's a big range of activities happening in our health systems. And what would you like to do? So as we think about how we position our planning processes to meet these goals, that was really important. We also were asking, how are you engaging clinical providers in deciding? Like, the CEO doesn't get to sit in the corner office and decide all of this, because we know at the end of the day, you're changing provider behavior equally to financial modeling as well. It is incredibly important to us that we are designing a system that will actually work for the people we're trying to serve. So again, how are we engaging specifically Medicaid beneficiaries in the design work? We ask for a variety of different data pieces from folks in terms of their client, both their health status, as well as their payer mix and so forth. So it's a fairly intensive set of work. We also were asking them to look at sort of community care coordination, because we have this ongoing evolution of our thinking that there's a tremendous amount of care coordination happening in the region. And part of what prompted our region to use our SIM dollars to try out pathways was we knew this to be true. And yet the needs of people who you are coordinating care for really run on a spectrum, much like our behavioral health spectrum. And so there's no way there is a one-size-fits-all model here. So in trying to think about what is actually already happening in the clinics that clinics are paying for and or making a pretty significant investment in, so that we have a really good sense of how that looks. So hold on to that piece. I'm going to come back to it. Yesterday, we launched our community-based care coordination inventory. So those of you who put forth LOIs related to pathways, you should have, and if you didn't, get mad at Hadley, because she was in charge of that. And I love to pass blame on.
Just to clarify, for folks who submitted as a care coordination entity, not necessarily a referral site, but someone who would employ or train care coordinators.
Yes, these are the people who are doing the care coordination. So we just launched that process with a sort of similar kind of flow of how are you doing care coordination, what type of training is required, sort of how does that fit, who are your clients, do you have Medicaid beneficiaries engaged, how are your providers engaged in your design efforts. We think this is slightly less work than the variety of ways we ask the health systems to cut their data, which is really the heavy lift, and we couldn't be more grateful because we haven't gotten the kind of data we want from the Healthcare Authority yet, so we're going the other direction to try and get there. And that is going to be due on August 4th. So now I'm going to go back to the slide of timeline. So we've just launched these 2 planning processes with very short timelines, because as an ACH and as a region, we have to submit our second phase certification. And this is the first time in ACH history that you could possibly not get exactly the same amount depending on which region you're at. So this starts to really move from, oh, everybody's equal to who's performing well so that you can earn the maximum amount of dollars. So in this certification, there's a number of areas around community engagement and governance and financial capacity and so forth. But one of the things that we think our region could score well on based on these inventories is the demonstration of how we are actually moving to people agreeing to do the work. So for those of you who've been sitting here for 2.5 years, this has been a lot of 30,000-foot trajectory. And we're all in agreement whole person care would be better and that we probably need to do a lot to improve our health status in our region. Now that we're moving into how are you going to actually change your business practices to align with this new world order, it's starting to get real. And we want to be able to demonstrate that we are showing both from our care coordination partners and our health system partners a deep commitment to this work. Now, by completing the inventory, you're not really committing to do anything other than step through the first phase of our planning process, of which there will be some additional steps moving forward. But I can't stress enough how important this work is in helping the region earn its full potential of those dollars, which is why there are financial performance incentives tied to completing those inventories. I think I want to go back to the sort of what happens, next slide, what happens next. So once these two inventories are done, we are starting to think about how we organize the work. So Brian was sharing what Greater Columbia is doing, and they have some sort of cohort groups on these project areas, is my expectation, or my understanding. I think we are working more towards a health system collaborative and then our community care coordination pieces as sort of the two structures, and that you'd be looking at in this healthcare transformation, how do both the required projects, so both bidirectional integration and opioid work, connect in with potentially maternal and child health or with diversion and transition. And I couldn't have had Mike tee up the question better to Brian, which is how can you actually do bidirectional integration if we have an EMS transition or a diversion issue without a systematic approach to it. So we really see this health system transformation centering on our bidirectional integration work, but that's like a meeting before you start figuring out all of these other connecting parts. So to go back to our optional project piece, we think that is where you start to see partnerships forming between health systems who, in the end, when we get to year 5 and 90% of our Medicaid contracts are in a value-based model, which is health systems taking risk for the health of their patients, they're going to have to be willing to pay for some of these optional project areas, either as a business expense or somehow that it is negotiated as a community. So I would say that we are so pleased with the diversity of projects, and we will be linking those up with the health system work. And we're not exactly sure how that is going to flow, and it will probably look different because we imagine there will be a Lincoln County health collaborative working, and they may, invite partner X, Y, and Z, which would be different than what Pend Oreille might do, and that MultiCare might have a different collaborative model based on their business model. So we're going to work really hard to make sure we're effectively connecting really the community partner delivery system with the health system so that Meals on Wheels isn't actually in 17 separate meetings and you spend all of your time on that. And yet there is a sort of core piece of this that we're all going to have to get comfortable with that gives the health system the ability to help contracting in that way, because they've got to see the value. Otherwise, this is a grant program for 5 years and we don't have the sustainability in place. So maybe I'll pause there because that was a lot. And it's the first time I've ever said it all in one thing, so that kind of felt good. Any questions?
Allison, the bonus, and I've missed a few meetings, so maybe I just don't know this. What happens to that money?
The phase 2 certification? Is that what you mean? Or
performance bonus?
So when Catholic Charities completes their care coordination, that one?
That 1 to 5 million.
Yes.
Yeah, what happens to that money?
So we've not made any decisions on that at our board meeting next Wednesday. They will adopt a policy budget on this. So they, the way we have allocated dollars so far, or how we expect to allocate dollars out of phase 2 money, is that only 5% would be utilized for administrative dollars. So the other 95% basically is building capacity within the community. The incentives that you're seeing for the health systems, for the care coordination comes out of that pot. We have hired KPMG to do some financial modeling. So as I go into what happens after that, I'll hit on this so that our partners, both health system and community partners, have a good sense of the financial model that will be required in order to move the needle. Because even though you have all of these different project areas and different metrics, some of them cross that we really want to make sure we nail, and we want to make sure our weighting is right. I think though there is interest across all 8 areas, we're a little skeptical that the interventions related to some of those areas get us to actually moving the metric. So we need to be able to figure out, can you earn the dollars and then reinvest them in a different way to meet that metric so that you aren't penalizing yourself over the longer period of time. Anyway, that's the KPMG part. We've also hired Providence Core to help build out and act as a both data aggregator and synthesizer for us so that we can develop a BHT-specific community dashboard with quick enough information update to be able to adjust strategy as we go and to hopefully accelerate our baselining of the metrics that are in there, as well as include some community-based or community identified metrics moving forward. I'm trying to think of some of the other expenses. We expect can we go to what's next slide? We expect that throughout this process, there will be more incentive dollars for partners in general. We're going to be working really hard. You will hear us now talk about performance payments because of accomplishments. Not we're going to give you money and then you'll tell us how you spent that money. You have to do the work to then be able to earn it. So a bulk of those dollars, as you move through it, really are getting pushed out based on accomplishment of goals and or sort of technical assistance. I think as you actually start to get into what it's going to take, many of us are going to need significant technical assistance in that way.
Thank you.
That's a great question, though.
So Allison, is that, so in a nutshell, you're saying kind of that's the infrastructure dollars for the community and different things like that? Okay.
And I would say that that's not exclusively. I think you will see some of the dollars that we will earn based on our project portfolio, which is $15 million, potentially $15 million, would also be infrastructure investment. I think in year 1 and 2, most of what any of us would spend dollars on will be how do you get the system ready. And that may be workforce investment, that may be technology investment, it may be, you know, redesigning a clinic so that you could have behavioral health services located there. Yes.
So Ron Poplowski, I just got a quick question before I go backtrack. And you kind of mentioned, Allison, that on the special projects that you were trying to get numerically an inventory and an understanding from the special projects that were presented, what of the 8 optional areas kind of gained traction, both globally, if you will, throughout the ACH or just geographic centric. So what were the results?
I think when you look at both the showcase evaluation portion and just where they were, it shows very clear geographic alliance around all eight areas. We didn't have any areas that I would say when you look across all of them that said, you know, Berry County isn't interested in X, Y, or Z type of thing. So I think you've got a good foundation for the health system work to look at those partners and how that might work.
But okay, so then a follow-up. So if it's not geographic, obviously there were some numericals that were from anywhere. I don't know. I don't have the numbers up there, but there were 2 8s, 2 9s, all the way down to 2 2s.
Right. I would think for the people who presented, nobody was not meeting what we would consider to be a minimum threshold of competence in that. And I don't think that was a assessment in the way you would think about a grant assessment in this. This feels more like a gut check of, did we have quality projects that were meeting not just the BHT staff's perspective of what geographic diversity across the 8 project areas with a level of understanding of what we're trying to accomplish, but we were able to test that with 80 people who were in the room completing that. So this is more of a checks and balances piece than if you didn't present there and you don't have a score, then you're out. You're not part of, you're not part of the mix. And I think we have evolved our thinking as we have seen how much pressure there is going to be on moving to value-based payment, that what it really taught us is we can't decide as an ACH we're going to do X, Y, or Z independent of what is actually fundable through value-based payments through health systems and those contracts.
So this is what you're saying is you have made no decisions, even though numerically it appears there is some, and that.
But that's not the full. I mean, I would say that is interesting information for partners as they decide how to move through who they want as their community partners. But not everybody presented in that way and was evaluated. So that it doesn't feel fair. It doesn't meet our fairness test in that from that perspective.
So you're not going to use that numerical data?
We're going to share that with our health system partners, for sure.
So when do who evaluates the project, and when do we get an answer on those?
So that'll be an iterative process, and I would just manage everybody's expectations that what is due here is still a very high level plan and may or may not say project X is funded. This is more, here's our baseline and the trajectory that we're moving to. We think that 2018 dollars to be earned, which is about 20 million, is really the implementation plan, where you would literally have, because I can see Lois here, Multicare saying, here's our integrated care model, here's who we're going to contract to support these types of projects, and then it would be run through our funding model so that they would know these are the amount of dollars that potentially are available if they hit all of those metrics. And we wouldn't expect that those plans would be complete until mid-18. We've not heard from the Healthcare Authority when, as a region, we'll submit the full implementation portfolio. So I don't have an exact time, but I think to just start managing everybody's expectations, we really expected that this deadline was a project plan and that we would know, we would have to know. So what's great is that we don't, especially because we still don't have our baseline data. and we've not had any community discussion around our funds flow.
So who decides then on those projects? Is that
Ultimately, the BHT board will make that decision, but I think what we're working on right now is this collaborative model and how this works only if, as a region, we have a cohesive plan. So I think that's where this sort of knitting together will happen, and I think that work starts to happen in November through, we would hope to have sort of the project plans for sort of the community feedback loop maybe in April of next year. But I think it's really important to note that we are not thinking about these as individual discrete projects with individual partners. It will be we're all in this together collaborative model of which these are the partners, and there is clarity on both roles and dollars that could be earned.
Yes. So if I have an understanding, the letters of intent projects are kind of like the skeleton. And then the next phase is really putting the meat on and figuring out how these individual bones are now going to knit together in a way that creates the more integrated structure as we move forward.
Yes.
Okay.
And I think we'll have sort of a high-level draft model to submit as part of our November work. And then let's just say May of 18 is where you would literally see Meals on Wheels is contracting with these 5 health systems to provide X services as it relates to meeting these 10 outcomes.
And then those scores that you had, Attorney had presented on before, kind of give us an indication of where we might want to put a little bit more meat, where we might want to augment, but they're not scores to make decisions. It's more of a guide, like you said.
Absolutely. And this is just a feedback loop. And we were intrigued by the data portion or the analytics part of this, and yet, clearly not a fair process when you look across. There were people who didn't get to present. And so it's a feedback loop. And we think it will be really helpful for both the community care coordination work to understand who partners that are really showing up and saying, hey, I'm ready to lean into this, as well as for the health system partners to be able to make that connection as well.
So we've been talking a lot about the projects, but those that are partners, I know you used one example, I don't know if that's just the rule of thumb, but is BHT going to become almost like the matchmaker of that, or do you want those partners to be proactively reaching out? Because it seems like if you're proactively reaching out, that's kind of might be bypassing the whole purpose of correct collaboration.
Yeah, I think it's got to be both. I mean, we're definitely playing an assertive role in folks that we see both demonstrating the commitment to the work that we have put forth, as well as expecting that at the end of the day, health systems have to decide who their partners are. And we, in our work with KPMG, one of the things that I thought was so telling of lessons learned from New York, which was make your community partnerships. And so the New York waiver model is based within health systems, and most of those health systems didn't do their community engagement with their community partners. So not beneficiary, but like with many of you, until fairly late in the process. And then there was a little bit of a scramble. And so one of the things that really stuck with me was, one, choose your partners really wisely, and 2, do it early. So this model sort of, I think, helps address some of that at the beginning point by, sort of surfacing a lot of our social determinant of health partners and interest in that way. I don't think I could in good conscience not tell you to be seeking out health system partners right now in general. So, and I worry that my health system partners are going to get overwhelmed by the 92 calls that they're about to get about how they're anxious too. So, I think we got to recognize this is sort of new territory, and let's do this in a smart way, which is where we will work really hard to make sure we're communicating really broadly about where we're at in the process.
So will there be an opportunity to do that a little more efficiently? I mean, you just kind of think conceptually about like almost like a fair or some sort where you can have a little more of, rather than, like you said, 92 people calling. I mean, that's A, not effective, and B, it just turns into just a really burdensome type of process. Is there more of like an open engagement that people can have in a more of a welcoming and less aggressive type of way that we can kind of do that?
Let me do a little bit of thinking. So one of the things that we just, for next month, we'll have this a little bit more baked for you, but this sort of probably from August 4th until this October 19th date, we're trying to figure out how you actually do this with enough customization to individual health systems, and yet we see some natural cohorts starting to pull together. So I think we'll spend most of August trying to sort through those inventories to see where folks are at. Many of them, I suspect, are going to tell us, we're doing this small pilot, or we have this small partnership with, many of you in the room, and we would be interested in how does that scale up, so that we are helping to facilitate that. I think there's a little bit of a how directive, this region does not like to be directed to do anything, versus how do you create efficiency for everyone. And I think there is a deep appreciation for just the capacity that exists. And even though we have some fairly robust systems, it isn't like they have tons of extra time as well. And then we think about some of our rural partners where that time is stretched even more. So I do think that there's some matchmaking, and that's I appreciate that piece of feedback. We'll add that into our planning process. Okay, did I cover everything on there? Yeah, I think so. Okay.
Once again, thank you all for bearing with us. We know this is a very complex and constantly changing system and plan, and we're all in this together, so we appreciate that we have you here and all of your patience through this. My last ask of you all is for a little bit of feedback on sort of an updated vision for BHT. So part of our phase 2 certification, that between $1 and $5 million document, is asking BHT to sort of update what they're calling a clear and succinct region-wide vision. We have 1,000 words to do this, and there's a whole lot else that they want us to include in that 1,000 words. So I'm sort of looking for some feedback and some truthing from the Leadership Council on some updated vision work that our staff did, but I want to hear if it still rings true to all of you. So we don't have as much time as I'd hoped, but my plan is just to sort of open this up. You all have a packet in front of you, and if you don't have it, we printed out some extras for whoever didn't grab one. So raise your hand if you're missing it. We also have an electronic version we'll send out later if you'd like to give some more in-depth responses. But I'm hoping that we can just take these next 15 minutes to just sort of break into small groups, give you all a chance to sort of read through our vision statement and give any feedback or comments, or especially on if you think that something has missed the mark for how you feel about our region, or if there's something missing that we need to add. Just to give you the quick overview, this we came up with in sort of a little planning session. I think a lot of you also have some of our previous vision, so we sort of adapted it, added to it, and expanded based off of some of the new roles that we've learned the ACH will be playing. So we came up with, BHT has a vision for an integrated community health system accountable to improving health through delivering culturally competent whole person care. In our region, every person, regardless of background, life experience, or environment, will live a high-quality life by ensuring access to stable housing, nutritious food, transportation, opportunities for education and training that allows for meaningful employment that pays the bills with some leftover for savings. How's that for a run-on sentence? And social support networks that allow for emotional, social, and psychological well-being.
Gotta save money.
There's a lot in there. So what I sort of did was, throughout this packet that you have, go through and pull out the different pieces of that vision statement. So in there we have some sort of guiding principles for BHT, a definition of how would BHT actually define the health system, what does health equity mean to BHT, what's the role of the ACH, What does accountability mean? So sort of a lot of deep diving questions. And we have 15 minutes. We also, the room's free afterwards. So if you're like really interested in sitting around talking about BHT's vision, I have no problem if you want to stay here. And we also, like I said, we have a survey. So if you're on the phone, you can type in this URL into your browser and fill out that survey and send it back to us anytime. We're going to keep it open for about 2 weeks. So at this time, I'm just going to sort of wrap us up and invite you all to look at this packet, talk to your neighbors, talk through any feelings you have about our vision statement. Myself and staff will also be walking around to get any feedback. And I'd also like to add that if anybody had questions for Brian that they didn't get a chance to ask, I'm volunteering him to be questioned, so feel free to grab him. Any questions, thoughts before I sort of wrap us up?
So this survey is this document on?
Yep, absolutely the same. If you don't feel like writing, you'd rather type, I will send this out with the notes by the end of the day, today or tomorrow morning.
Haley, can you go back to the vision? Perfect.
All right. And with that, I think I'm going to go ahead and wrap up the meeting. Folks on the phone, I'm going to mute us in the room because there's going to be some discussion inside, but I'll keep the chat box open if you have any questions. Thank you all for a lovely July meeting, and we will see you soon.
Yes. You bet.
What is your name?
That is lady. This is
I'm a board member for the.
This is that's our original.
Original, so this is updated.
Okay. All right. Oh, okay.
This is not what I wanted to ask you, but it's like, look, it's missing is robust healthcare services. It's like all of the social determinant things, but not the actual care. So.
Excellent feedback. Excellent feedback.
See, and this one doesn't match that
Anyway.
either, so.
Okay, you know when the first meeting organized, like it's all getting together, right? I'll just go with my you give that today. Friday.
Yeah, this is that one.
Here.
It was?
Yeah, it's got all.
I mean, they have their website that tells that.
So I think it's missing.
They don't
that
always
statement on the
update
whole
the,
person, integrated whole person
Yeah.
care. 'Cause that's not
You've
in here,
experienced
is
that.
it? Yes.
Why? Integrated community health system. Allison, I'm taking your chair.